Hi everybody, this is lecture 7.1. This time we'll be talking about mental disorders. So in this time we're going to be talking about stigma in relation to mental disorders, types of mental disorders, social institutions and how they respond to mental disorders, how mental disorders relate to our identities, particularly minority identities, and some sociological perspectives on mental disorders. This isn't a topic that really sociology dominates. Obviously, psychology kind of controls and guides us through a lot of this discussion. But certainly there are sociological factors involved in this, and understanding mental disorders is really important to understanding sociological deviance in many cases. So let's talk briefly about stigma and mental disorders. Mental disorders and illness are very common. About 50% of American adults suffer from a mental disorder during their lifetime. And that's not normally how we perceive the issue, right? We think of people with mental disorders, of people who are crazy, as being people we don't know, people we don't have experience with. But half of us have some issue with mental disorders over our lifetime. The most common mental disorder is depression. It's known as the common cold of mental illness. Other common mental disorders include anxiety disorders, bipolar disorder, and learning disorders or learning disabilities. Stigma makes getting over your learning disorders, your mental disorders, any of these brain problems difficult. We have talked about stigma previously in this class, but let's just go over it again. Stigma is the process through which we choose a portion of the population and other them, right? So we take these people and we say, look at those people, they are the bad ones, they are not us. And these people are often seen as being less than the normal population. They're seen as being not normal, and they are often used as people that we blame our problems for. They are scapegoated. There are many types of mental disorders, and there are two general ways to perceive mental disorders. First, we can use the biomedical lens, which is looking at how the chemicals work in the brain itself, or we could use the psychological lens, which deals more with how people think, looking past those actual chemical processes. The biomedical view of mental illness views mental illness as similar to physical disease. And this outlook is accepted by the American Psychiatric Association. Remember, there is a difference between a psychologist and a psychiatrist. Psychologist is someone who studies the way that the brain works, and they could treat patients. That is something that psychologists sometimes do. A psychiatrist, then, is a psychologist. It's a type of psychologist who specializes in those biological processes of the brain. And a psychiatrist, if you go through the various processes of that profession, a psychiatrist can prescribe medications. There's also the psychological view that mental illness signals emotional problems of a psychological origin. And psychologists break down mental illness into three general categories, and I'll give more details on each of these, but those three categories are psychosis, neurosis, and personality disorders. A psychosis is, and there are many different kinds of varying severity. A psychosis is a loss of touch with reality. One of the most severe and probably best well known, if not best understood, is schizophrenia. Schizophrenia is characterized by thinking and talking in unconventional, illogical, or ambiguous ways. Those are the symptoms of schizophrenia. Schizophrenia is characterized by hallucinations. So the schizophrenic individual either hears things that don't exist, or they start seeing things that don't exist. Often it's one or the other. It is the rare schizophrenic individual that has both of those things. And schizophrenia is not to be confused with multiple personality disorder, which it often is for some reason. Multiple personality disorder is a disorder in which there are multiple, it's said to be multiple people existing in the same person. Schizophrenia is about hallucinating and seeing things that aren't actually there. There's also, within psychosis, manic depressive disorder, also known as bipolar disorder. This is the fluctuating between two opposite extremes in mood. So, fluctuating between mania, so this is great elation, exuberance, or excitement. And in and of itself, mania isn't usually treated on its own because mania to the person that's suffering from it isn't seen as a bad thing, except in that mania can drive individuals to do kind of irrational things like all of a sudden deciding to add a extension onto your house, or just taking on a really kind of crazy project all of a sudden. And where mania really falls apart is within manic depressive disorder is when the depression hits. So they have this mania, and then when the mania is over, it swings to the opposite end into depression. And that depression is made worse than your standard depression because it just came off a mania, and the manic depressive is put into a very deep, very powerful, very devastating sadness. So moving on from psychosis, a neurosis is effectively a less severe psychosis. So the individual is not perceiving reality as it actually exists, but they're not hallucinating. Their reality is just distorted. And the neurotic person is able, even in a deep neurosis, able to behave in socially acceptable ways for the rest of society, even if their mental disorder might be making them miserable. The neurotic symptoms prevent the sufferer from being effectively as happy or as effective in society as they want to be, but a neurotic person rarely impacts other people in the way that a psychotic person does. There are multiple types of neurosis. Anxiety is one of the more common types of neurosis. This is characterized by a generalized apprehension, and a common type of neurosis anxiety is known as generalized anxiety disorder. This is a neurosis in which the individual feels kind of uneasy all of the time for really no discernible reason. This then is compared with a phobia, where the individual is afraid of a specific object or objects or a series of events, right? So a phobia is a fear of a specific thing, while generalized anxiety disorder is a phobia of just kind of everything. Specific phobias include arachnophobia, fear of spiders, agoraphobia, fear of the outside, so not wanting to go out of your house, hydrophobia, fear of water, and phobias are extreme and irrational. A little bitty spider won't cause most people to kind of lose it, but the arachnophobic person, it would. Yeah. And both, yeah. Another type of neurosis is obsessive compulsive disorder. This is when thoughts interrupt train of thought and is typically tied to ritualistic type action. The most common or well-known obsessive compulsive disorder is obsessive hand washing. And again, that's not, if you like to wash your hands, that's one thing. If it is impacting your life or deteriorating your quality of life or the way you do things, that's when it starts to be classified into a neurosis. Depression is another neurosis. This is a feeling of sadness, dejection, and self-depreciation. This is more than just occasional sadness. Everyone has a bad day, right? Everyone might have a bad week or a bad series of events. But depression is more chronic and more long-lasting. And it is a very common disorder. A lot of people suffer from depression just once for a couple months and then it goes away. A lot of people have ongoing depression, and it is a disorder that is very treatable with medication and some therapy if that works for you. A lot of people suffer from depression. So we had our neuroses, we had our psychoses, and now we have psychological disorders. Oh, no, wait, sorry, these are still neuroses. These are still neuroses, sorry. Within neurosis, we have psychophysiological disorders. Some of these are hysteria, psychosomatic illnesses, and conversion disorder. Hysteria is categorized by extreme emotional displays, such as crying or screaming. And hysteria is a real neurosis. With that said, when the concept of hysteria was originally studied, it was seen as being a woman's disorder, and women effectively in the early 1900s, in the 1800s, who would, quote, be defiant to their husbands or not listen to men's authority, because basically they didn't want to always be listening to men. They were often categorized as being hysteric, right? So this is a historically problematic disease because basically anytime a woman didn't listen, she was hysteric. And many women were put in psychological facilities for being hysteric. With that said, hysteria is a real psychological disorder, but many people were accused of having it in the past that absolutely did not have it. Another psychophysiological disorder, I'll say that right one of these times, is psychosomatic illness. So this is physical illness caused by a mental disorder. So this type of neurosis might be weaved in with another neurosis, such as generalized anxiety disorder or a phobia of being ill, and this disorder causes the individual to actually suffer from the physical symptoms. This is very much a matter of the brain being a very powerful organ, and the brain can cause symptoms in the body. To someone who is suffering from psychosomatic illness, these are real symptoms. This is real pain. It absolutely exists. But the issue is not being caused by a disease. It's not being caused by an injury. It's not being caused by a infection. It's being caused by a process in the brain. It's still very real, though, especially to that individual. And conversion disorder. This is it's an interesting one. It is a type of neurosis. It is very rare. It's you don't worry about falling into conversion disorder, but it is basically caused by instant paralysis, and the actual cause of this disorder is not known. It is often instigated by a traumatic event. But yeah, your brain can just kind of decide, oh, all of a sudden you're paralyzed. But don't worry about that. It really is exceedingly rare. Now, here is our actual third category. Sorry about that mix-up a little bit earlier. Personality disorders. Personality disorders represent a wide spectrum of disorders. This is a general category of deviant behavior, and personality disorders are different than both psychotic disorders and neurotic disorders. Personality disorder is categorized by a blatant disregard for society's rules and is thought to be linked to a lack of moral development. So the person understands what they're doing is against the rules. They just don't care about the rules. And they don't care about other people. And it might be caused by, given each individual with every disorder is a little bit different, but it might be caused primarily by a failure to develop a conscience, acquire true compassion, and to the ability to form meaningful human relationships. With that said, certain political figures could be thought to possess various types of personality disorder. Specifically, narcissistic personality disorder is a mental disorder that if you're aware of the symptoms of it, you can look at not just specific politicians, but many politicians and many corporate CEOs, many leaders. There is something to narcissistic personality disorder and believing you can do these amazing things. You're the best person for the job. You should be absolutely in charge of running the country, right? It takes a certain degree of absolute confidence to do that. And you aren't necessarily a narcissistic person if you want to be president, but narcissism could cause somebody who had it to think that they could be president. So, now let's talk about mental disorders and our identities. Many social factors have been studied as they relate to mental illness. This includes class differences, gender differences. For example, rich people are able to get better care for mental illness. And working class or poor people, particularly those working class and poor people that have been unable to get an education and be exposed to the kind of information you're being exposed to now, are more likely to stigmatize mental illness, right? If among uneducated populations, it's more difficult to get help because maybe necessarily your health insurance isn't the greatest. But it's more likely that if you are working class or poor, or middle class even, you're likely to not get help because you think, oh, well, I'm not crazy, oh, crazy people are bad, those kind of things. There are also gender differences. Women are more likely to be categorized as mentally ill. This also has to do with social factors. So there's just a concept that women are more emotionally fragile, that women are less able to deal with their feelings, right? And this causes people to perceive women as being mentally ill more often than we perceive men as being mentally ill. With that said, women are more likely to actually get help when they are suffering from mental illness. So it's a gender dynamic. It doesn't just swing one way. Sure, women are more likely to be effectively called crazy, but they also are more likely to actually get help. Age, race and ethnicity, and where you live, be it urban and rural, also impact a mental illness. So children are less likely to be treated for mental illness, and this is for a variety of reasons. During a child's developmental cycles, they exhibit, and I can talk about this firsthand, they exhibit things like narcissistic personality disorder. They exhibit absolute selfishness. They exhibit manic depression, right? They exhibit all these mental illnesses, but it isn't long lasting. It's real short. It can maybe be a day, a week, maybe a month, right? But these cycles of childhood development are just part of the brain coming together, right, as the child's brain develops. So children are less likely to be treated for illnesses because it's kind of part of growing up. But also, if those illnesses would really take place, right? if a child would actually develop a neurosis or depression, they would be less likely to actually get help because maybe the parent would go into a little bit of denial about it and just think, oh, this is just a phase. Well, that phase has lasted 3 years now. Maybe we need to do something about it. Those are kind of the barriers to treating children. Similarly, children are more likely to be misdiagnosed with diseases such as ADD or ADHD, attention deficit disorder, and attention deficit hyperactivity disorder. These are illnesses actually that often manifest in childhood, and especially in cultural cycles. We're kind of out of a cultural cycle now that like to prescribe children ADD and ADHD medicine without really treating the underlying illness, right? So a lot of kids in the past have been treated with these drugs to probably to an overextended degree, and certainly a lot of kids did have and do have ADD and ADHD, and they do stop. Those symptoms do tend to stop in adolescence. Some adults do have, again, these diseases as well, but children have a greater chance of being misdiagnosed with these disorders because some ADD and ADHD behavior, again, is part of being a child, right? Yeah, and I can't diagnose children with disorders. I'm not a psychologist or a psychiatrist. Race and ethnicity. Certain groups are still likely to stigmatize mental illness. African American populations, certain other populations are more likely than other populations to have cultural and subcultural stigmatizations on illness, and that is our artifacts of those groups having been discriminated against in the past. Black people do have reason, based on past treatment of their race by officials, to not necessarily believe when people who aren't black say, oh, you need mental help, right? Because in the past, in the 40s, 50s, 60s, they had been mistreated by medical communities. And if you really want to learn more about that, it doesn't specifically have to do with mental disorders, but it has to do with mistreatment of black people in a medical sense. There's a really great book called Bad Blood. It is about the Tuskegee syphilis experiment. It's an amazingly good book. I recommend it anytime I can. The urban and rural environments. So mental health facilities are not available in many rural areas, and for that reason, more people in rural areas do suffer more from their mental disorders. And add to that, people are generally less aware of mental disorders in rural areas, so that also maintains the stigma of effectively the bad, crazy person. This also ties into what I was just talking about mental disorders and our identities. Mental disorders have been used historically to discriminate against minority groups, right? So as I mentioned, women were seen as being prone to, quote, being hysteric. And hysteric during that era when women were just accused of being hysteric could be any behavior of a woman not listening to a man. Homosexuality, for example, was diagnosed as a disease by psychologists as late as 1987. That is within many of our lifetimes, right? So gay people, it was seen as being a mental illness. And similarly, African Americans, by psychological communities, by scientific communities, were considered mentally inferior for much of the 20th century. Now, given that's farther back, right? That's into the 30s and 40s when that died away. But still, that is in our parents' and grandparents' lifetimes. Even when, and this is kind of taking a shift. This is more talking about how the existence of mental disorders can change, based on societies and cultures. But mental illness can be specific to cultures. So, for example, there is a distinct cultural phobia within Latin America of people fearing that their souls or their personal essence has left their body, right? So people are afraid that, okay, I'm in my body, I'm thinking, but is my soul still here, right? That is a cultural phobia within Latin America. In Malaysia, people who are startled and who get spooked, basically, they sometimes break out in screaming and swearing fits for maybe hours or even days. And that doesn't happen in other cultures, right? It's kind of a specific mental disorder response to being startled. And it's incredibly interesting sociologically. Similarly, in South Korea, and you see a little bit of this in Germany and a couple other spots in the world, people are afraid of running air in their bedrooms, in their sleeping areas. And it's thought, specifically in South Korea, that if you leave a fan running in your bedroom, that you will suffocate. Right? There is no medical evidence to show this. There's no reason to believe that that could ever happen, but yeah, it's thought that the fan can suffocate you in South Korea, and people have a phobia of that, and people specifically act in specific ways because of that. That phenomena is known as Korean fan death. Like I said, though, it's never actually killed anyone. It's just kind of a fear people have. So now let's talk about our social institutions and how they impact mental disorders. Historically, mentally ill people were treated incredibly badly. But as treating of mental illness has progressed, we have gotten much better at treating it. But for this reason, this might be a cause of some of the stigma associated with mental illness. So in the past, we've done primitive lobotomies, right? We've done surgery on people's brains to cut up parts of the brain to basically just cutting any part that makes sense or doesn't make sense at the time. Primitive electroshock therapy. And I say primitive with lobotomies and electroshock therapy because for certain very specific disorders in the modern day, those can still be used. But they were abused in the past. Over-medication of individuals. There was a medication known as lithium in the 1950s and 60s that was over-medicated. This is before we had medications like Paxil, Lexapro, Prozac, the more modern medications. Lithium was used to try to even out people's mental problems. And lithium still can be used in specific circumstances, but lithium is a drug that can get out of control pretty quick. Conversion therapy for homosexuals. It was once accepted by the medical community that you could be converted from being gay. Now that's completely rejected from the medical community. And again, I can't overestimate enough how poorly we treated women because we labeled them as being hysterical. Mentally ill people are often viewed by the general public as being dangerous, as being dirty, as being unpredictable, worthless, and the brunt of jokes, right? It is very cruel that we make fun of people for their mental illness, for something that they can't help. And courts have often put people in mental institutions or prisons because of crimes accused against them. This includes involuntary hospitalization and declaring people incompetent to stand trial. And this is where a lot of, in the past, insanity defenses came from. The insanity defense almost never actually works in most court cases, and that's because most people have acknowledged that it had been overly abused in the past. With that said, if you can establish an insanity defense, it probably is because the person is actually mentally ill and isn't responsible for their actions. It's a really high legal bar. Mental hospitals are known as are a type of total institution, which you may have studied in your other sociology classes if you've taken them. A total institution is one in which a person is cut off from larger society and is forced to lead an enclosed, regimented life, and often leads to dehumanization. There are modernized asylums, and basically these mental hospitals have highly limited funding. Those mental hospitals that still do exist are almost always private institutions, and most of the people in those mental hospitals are very, very troubled, very far gone. Most of them are often catatonic, unable really even to communicate with the outside world. Mental hospitals, especially in the past, routinely use tranquilizers and other drugs to alleviate symptoms, that rather than actually trying to deal with the actual mental disorder. And this has been overused in the past, right? So when someone's put in a mental hospital, a lot of times they're seen as being untreatable, even if they could get better. But again, with that said, many of the people that actually wind up in mental hospitals now that they are so poorly funded, a lot of them may actually be hopeless cases. Now let's look at a few perspectives on mental disorders before we're done. There are three ways of treating mental disorders. We have the medical model, the psychosocial model, and the labeling model. And obviously, some of these are better than others at treating them. The medical model interprets mental disorder as a mental illness similar to a physical disease. Thus, disorders are identifiable and diagnosable, and you can say, absolutely, this is causing this. And you treat, through medical means, a psychological disorder just like you would treat a physical disease. And the major way to do that is by medication. And I'll get with that said, any good doctor, any good psychologist will say, okay, you're on this medication, you also should be in therapy. That's the generally accepted model is, okay, you take this medicine, but you also go to therapy. The psychosocial model is based loosely on the psychoanalytic model, which was based on Sigmund Freud's work. Freud stated that disorders are the results from conflict in personality. Therefore, our human relationships and the way our human brains work are actually what causes mental disorder. Similarly, social stress theory interprets stress as a major contributor to the development of a mental disorder, and obviously multiples of these theories can work with each other. And finally, the labeling model. And this is the model favored by sociologists, not necessarily because we think it's the most true, which we do think it's true, but because this is the thing that sociologists study. The labeling model views mental disorders not necessarily as a sickness, but as a way of being different. And disorders are only a label imposed on people with some disturbing behaviors. So who is the crazy person? Who is the ill person? Sociologists point out that that is a social process. And some labeling theorists, some is the key word, try to encourage patients to embrace their disorders if possible. So that's not to say we would encourage people to go off their medication and all of those things. That can be very dangerous. But we would encourage the individual to try to figure out, well, what about this thing in your brain that makes you different? What about it can you use, right? Does your anxiety make you more vigilant, make you a better parent, make you a better worker? Can you use this to your advantage? And if it's not making you miserable, maybe it's all okay. That's one way of viewing it, and that's one lens. Okay, that is it for this lecture. And if you have any questions, as always, please let me know.